Good afternoon, everyone. Thank you for joining us today for the Skilled Nursing Facility Quality Reporting Program Drug Regimen Review conducted with follow-up with identified issues. My name is Sharon Purcell, and I will be your host and moderator today. I will start off by going through a few housekeeping items. This webinar is being recorded. It will be later posted to the CMS Skilled Nursing Quality Reporting Program webpage. We will provide you with details on accessing the recording via email when it is available. If you would like to use the closed captioning screen, there's a closed captioning window on the bottom near the middle of the screen. All phone lines will be on mute for the duration of the presentation. Due to the large number of attendees on today's webinar, we are unable to field questions over the phone, but you can submit questions electronically. If you have a question at any point throughout today's presentation, please enter it in the chat panel. We will answer as many questions as possible during the presentation. Responses to all submitted questions will be published on the SNF Quality Reporting Program webpage. Also, an email will be sent to you when the Q&A document is available. For downloading the handout materials, if you would like to, you can download today's presentation slide deck. Click the Media Library icon located at the top of your screen to access the shared files, and then click the green arrow next to the file name in order to download the presentation. The presentation slide is also posted to the SNF Quality Reporting Program website in the download section. If you would like to display the slides in a larger view on your screen, click the title of the PowerPoint presentation and the option for full screen will appear. If you click on the full screen, you will change your view only to be in a full screen mode. To exit full screen, hit the Escape key on your keyboard to return to a normal view. Now, throughout today's event, we will be using polling questions. Polling questions allow the speakers to ask questions to gauge your understanding of the material being presented. Each polling question will appear at the bottom of your screen. Review the answer choices offered and choose your answer. Use your mouse to click on a circle to the left of your response. There is no need to hit submit. Once you choose your answer, it will automatically be submitted for you. You can change your answer at any time before the poll is closed. Your answers are confidential and will be reported in aggregate percentages. Now let's test the polling function. You should now see the polling question appear on your screen, on the webinar screen. The question is, how many people, including yourself, are in the room attending this webinar? Now please choose your answer from the choices offered. I see responses coming in. Choose your answers. Great. As you can see, polling is very simple. We look forward to you participating throughout the presentation using the polling. A disclaimer has been provided for your review. Please keep in mind Medicare policy changes frequently, and please refer to the links provided in the presentation for the source documents. We encourage you to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. Now, today's presentation will be provided by Terry Ng. Terry is a research public health analyst in the Quality Measure and Policy Program in RTI's Division of Health Services and Social Policy Research. Since joining RTI, Terry has worked on several Centers for Medicare and Medicaid Services projects. Terry currently serves as the long-term care hospital lead for the development and maintenance of symptom management measures, project funded by CMS. This project is focused on the development, maintenance, and reevaluation of quality measures for post-acute care settings to develop and implement quality measures for the LTAC quality reporting program. In addition, Terry is the RTI lead for the Drug Regimen Review quality measure and a member of the analytical teams for the evaluation of the initiative to reduce avoidable hospitalizations among nursing facility residents with the Center for Medicare and Medicaid Innovation, where she conducts semi-structured interviews with skilled nursing facility leadership and clinical staff as the Missouri State Lead. Terry has extensive clinical nursing leadership experience in surgical, critical care, cardiovascular, and medical nursing at Brigham and Women's Hospital. We've also provided acronyms that will be displayed throughout the presentation. The list of acronyms will be displayed throughout today's presentation on slides 9 through 10.
Thank you.
We will conduct today's webinar with a question and answer session and finally a wrap-up. We are pleased to have such an experienced and knowledgeable speaker present on today's webinar. Thank you, Terry, for being here today. It is now my pleasure to turn the session over to the presenter, Terry Ng. Terry, the floor is yours.
Thank you so much, Sharon. Welcome, everybody. I understand that there's over 1,000 people on the call today, and I'm so gratified that so many people are interested in learning about the drug regimen review conducted with follow-up for identified issues. In the next hour, I will provide an overview of the new Section N medication data elements that have been added to the MDS, explain how to code them, provide practice scenarios, and explain how the quality measure is calculated. I'll use the term data items and data elements interchangeably. At the end of this presentation, you should be able to identify the intent of the DRR items in Section N, recall the purpose of the new items and coding options, apply coding instructions to accurately code practice scenarios, and recognize the elements of the new DRR quality measure. We will not be going over the case study during the presentation today, but rather the case study will be posted at a future date post the presentation. The case study was part of the SNF training that was held recently in person. The DRR is an assessment-based cross-setting process quality measure adopted to meet the requirements of the IMPACT Act domain of medication reconciliation. Data collection for skilled nursing facilities will begin October 1st, 2018. This slide shows the two new drug regimen review items that you will complete at admission, and we are going to go through all of the terms used in the items in a few minutes. The drug regimen review admission data elements require that you document whether a PAC provider conducted a drug regimen review upon the patient admission and whether clinically significant medication issues were addressed in a timely manner when identified. I'd like to point out that the data set has undergone a revision as of August 17th. And so the final MDS 3.0 RAI manual, and which is version 1.16, and the MDS forms version 1.6.1, which are effective will be effective October 1st, 2018, were posted, as I said, on the CMS website. What I'd like to point out on this slide is that changes have been made to N2001 to remove the skip pattern to Section O. This applies to N2001 equals 0, no, and a 9, non-applicable. There are also changes to the labels for all three data elements. N2001 drug regimen has added complete only if A0310B equals 1. For N2003 medication follow-up, complete only if N2001 equals 1. And N2005, which you'll see on the next slide, complete only if A031OH equals 1. All affected screenshots will be updated when the post-training versions of the presentation are posted. The drug regimen review has a single discharge data element, and the purpose is to document whether PAC providers conducted a drug regimen review upon the patient admission and whether clinically significant medication issues were identified and addressed in a timely manner when identified throughout the resident's stay. This discharge item includes the entire stay, admission through discharge, and this is a key point to remember as we go through the presentation. The intent of the drug regimen review items is to document whether a DRR was conducted upon the resident's admission, start of the SNF PPS stay, and throughout the stay through Part A PPS discharge, and to identify clinically significant, make sure that clinically significant medication issues were addressed in a timely manner when identified. The next several slides I will present key definitions that you will need to accurately code the DRR data elements. The first one is, what is a DRR? The drug regimen review includes medication reconciliation, a review of all medications a resident is currently using, and a review of the drug regimen to identify and, if possible, prevent potential clinically significant medication adverse consequences. As defined in the State Operations Manual for SNFs, reconciliation of medications is a process of comparing pre-discharge medications to post-discharge medications by creating an accurate list of both prescription and over-the-counter medications that includes the drug name, dosage, frequency, route, and indication for use for the purpose of preventing unintended changes or omissions at transition points in care. What does the DRR include? The DRR includes all medications prescribed and over-the-counter, including nutritional supplements, vitamins, and homeopathic and herbal products administered by any route. The drug regimen review also includes total parenteral nutrition and oxygen. A clinically significant medication issue is a potential or actual issue that, in the clinician's professional judgment, warrants physician or physician-designee communication and completion of prescribed recommended actions by midnight of the next calendar day at the latest. Clinically significant means effects, results, or consequences that materially affect or are likely to affect an individual's mental, physical, or psychosocial well-being. And these effects can be positive by preventing a condition or reducing a risk, or they might be negative by exacerbating, causing, or contributing to a symptom, illness, or decline in status. This is a key point to remember on this slide in accurately coding the DRR data elements. Any circumstance that does not require this immediate attention is not considered a potential or actual clinically significant medication issue for the purpose of the DRR items. The next slide shows examples of clinically significant medications. Clinically significant medication issues may include, but are not limited to, medication prescribed, documented medication allergy or adverse reaction, excessive or inadequate dose, adverse reactions to medications, ineffective drug therapy, drug interactions such as serious drug-drug, drug-food, and drug-disease interactions, duplicate therapy, for example, generic name and brand name are equivalent drugs are co-prescribed, or if there's the wrong resident, drug, dose, route, and time errors. Continued on this slide, clinically significant medication issues may also include medication dose, frequency, route, or duration are not consistent with the resident's condition, nor the manufacturer's instructions or applicable standards of practice. It could also be a use of a medication without evidence of adequate indication for use. It could be the presence of a medical condition that may warrant medication therapy. It may include omissions, or it may include non-adherence, which may be purposeful or accidental. Other examples may include use of a medication without evidence of adequate indication for use, presence of a medical condition that may warrant medication therapy. For example, a resident with primary hypertension does not have an antihypertensive medication prescribed. The next important definition is contact with a physician. Two-way communication is essential for completing the drug regimen review data elements accurately. Two-way communication means communication to the physician to convey an identified potential or actual clinically significant medication issue and a response from the physician to convey prescribed recommended actions in response to the medication issue. In order to meet the requirements of the measure, you need to communicate and convey the information to the physician, and you need to have received a response from the physician so that you can then address the issues. This is two-way communication. This slide shows examples of how that two-way communication may occur. It may be in person, by telephone, voicemail, electronic means, fax, or any other means that appropriately conveys the resident's status. This slide just emphasizes that communication is directly with the physician-designee. The next definition is, how is a physician-designee defined? We have received questions from providers asking how a physician-designee is defined and where you can find that information. According to Appendix PP of the State Operations Manual, a physician-designee is referred to as a physician/practitioner, which may be a physician assistant, nurse practitioner, clinical nurse specialist, and it means the individual who has the responsibility for the medical care of a resident. The role of a physician-designee, non-physician practitioner, is defined by federal and state licensure regulations. I suggest that you refer to these regulations to determine which clinicians are licensed to act as physician-designees. Medication follow-up is another key definition, and this medication follow-up is used in describing N2003, and it is the process of contacting a physician to communicate an identified medication issue and completing all physician-prescribed recommended actions by midnight of the next calendar day at the latest. In the next section, I will present key information that will assist you in conducting the drug regimen review and how to code the data elements. In order to code the DRR items, you are going to need to refer to and review a number of the resident's medical record sources for this information. Where are you going to find this information essential to code these 3 items? Medical record sources include medical records received from facilities where the resident received health care, the resident's most recent history and physical, transfer documents, discharge summaries, medication lists or records, clinical progress notes, and other resources available. Recently, we were asked if using information from an incident or an unusual occurrence report was an appropriate source for coding the data elements. And the response to that question is that this would be an example of one source of information that might be helpful in coding the items. Discussions, in addition to medical record sources, discussions, including discussions with the acute care hospital, other staff and clinicians responsible for completing the drug regimen review, the resident and the resident's family, significant other, may also supplement and or clarify the information gleaned from the resident's medical records. Your facility may decide to use a specific or central means of gathering this data to make it efficient to locate information relevant for coding this measure. This is a key point. It is essential that you have documented identification of potentially clinically significant medication issues and the timely two-way communication information and the follow-up actions that address the issue identified. Item coding needs to reflect what was documented. The drug regimen review process is a multidisciplinary team review of the resident's medications. The Centers for Medicare and Medicaid Services does not provide guidance on who can or cannot code the DRR items. I suggest that you refer to your facility, federal, and state policies and procedures to determine which SNF staff members may complete a DRR. Each facility determines their policies and procedures for completing the assessments, and each facility provides resident care according to their unique characteristics and standards. Now we will go through the data elements, N2001 through N2005. And N2001 is located on the admission assessment. As previously shown, there are 2 admission assessment data items to complete on the MDS. N2001 identifies whether a drug regimen review was conducted upon admission, start of the SNF PPS stay, or as close to the actual time of admission as possible, and whether the clinician identified any potential or actual clinically significant medication issues. Here's what N2001 looks like on the assessment with 3 choices for coding that I will review. For N2001, the item rationale includes health-related quality of life, and resident planning of care. Potential and actual resident medication adverse consequences and errors are prevalent among healthcare settings and often occur during transitions in care, as we are all familiar with. Adverse consequences related to medications may result in serious harm or death, emergency department visits, and or rehospitalization, and can affect the resident's health, safety, and quality of life. The drug regimen review is intended to improve resident safety by identifying and addressing potential and actual clinically significant medication issues at the time of the resident's admission, start of the SNF PPS stay, and throughout the resident's stay through Part A PPS discharge. The State Operations Manual defines an adverse consequence as an unpleasant symptom or event that is due to or associated with a medication, such as impairment or decline in a resident's mental or physical condition or functional or psychosocial status. It may include various types of adverse drug reactions and interactions. For example, medication, 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 food, and medication, disease. The drug regimen review is an important component of the overall management and monitoring of a resident's medication regimen. Prevention and timely identification of potential and actual medication-related adverse consequences reduces the resident's risk for harm and improves quality of life. It's important to educate staff in proper medication administration techniques, adverse effects of medications, and observing these adverse effects. You may want to implement a system to ensure that each resident's medication usage is evaluated upon admission and on an ongoing basis, and that risks and problems are identified and acted upon. Now we'll go on to the steps for assessment that will assist you in accurately coding N2001. So you are going to complete a drug regimen review upon admission, as I've indicated, or as close to the actual time of admission as possible to identify any potential or actual clinically significant medication issues. You're going to review the medical record documentation to determine whether a DRR was conducted upon admission, start of the SNF PPS stay, or as close to the actual time of admission as possible to identify any potential or actual clinically significant medication issues. We've already reviewed medical record sources that you may turn to help assist with this assessment. You are going to code this item if A0310B equals 01. N2001 asks, did a complete DRR identify potentially clinically significant medication issues? You are going to code this data element 0 if no clinically significant medication issues were identified during the DRR. You're going to code this data element yes if one or more clinically significant medication issues were identified during the DRR. You will code 9 non-applicable if the resident was not taking any medications at the time of the drug regimen review. A dash value is a valid response for this item. However, the Centers for Medicare and Medicaid Services expects dash use to be a rare occurrence. We will practice coding all three data items and the available responses during this presentation. The next data element is N2003 medication follow-up. N2003 identifies whether the facility contacted a physician and completed all physician-prescribed recommended actions by midnight of the next calendar day in response to all potential or actual clinically significant medication issues identified upon admission, and as I said previously, start of the SNF PPS stay. N2003 asks, did the facility contact a physician or physician-designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issue? You will code this data element either no or yes for the second admission question. And similar to N2001, we have health-related quality of life and the resident's planning of care as part of the rationale for these data elements. Integral to the process of safe medication administration practice is timely communication with the physician when a potential or actual clinically significant medication issue has been identified. Physician-prescribed recommended actions in response to identified potential or actual clinically significant medication issues must be completed by the clinician in a time frame that maximizes the reduction in the risk for medication errors and resident harm. When a potential or actual clinically significant medication issue is identified, prompt communication with the physician and implementation of prescribed actions is necessary to protect the health and safety of the resident. As I've indicated, this item is completed if a potential or actual clinically significant medication issue is identified during the admission drug regimen review. In terms of the steps for assessment, you are also going to review the medical record sources that we've previously discussed. To accurately code N2003, you need to determine whether two-way communication between the clinician and the physician was completed by midnight of the next calendar day, and all physician-prescribed recommended actions were completed by midnight of the next calendar day. This criteria, I want to emphasize, this criteria needs to be met for all potential and actual clinically significant medication issues that were identified upon admission. You are going to code N2003 no if the facility did not contact the physician and complete prescribed recommended actions in response to each identified potential or actual clinically significant medication issue by midnight of the next calendar day. You are going to code this data element 1, yes, if the facility contacted the physician and completed the prescribed recommended actions by midnight of the next calendar day after each potential or actual clinically significant medication issue was identified. I'd like to share a few coding tips with you. If the physician prescribes, recommends an action that will take longer than midnight of the next calendar day to complete, then code 1 yes should still be entered. If by midnight of the next calendar day the facility has taken the appropriate steps to comply with the prescribed recommended action. Example of this might be a physician-recommended action that would take longer than midnight of the next calendar day to complete. So for instance, if a physician writes an order instructing the clinician to monitor the medication issue over the next 3 days and call if the problem persists. Some examples of why you would code 0 no. The clinician did not communicate all identified clinically significant medication issues to the physician or physician designee until after midnight of the next calendar day. So you would code 0 no in that instance. Another example is the clinician communicated all identified clinically significant medication issues to the physician by midnight of the next calendar day, but the clinician did not receive a response from the physician to communicate the prescribed recommended actions until after midnight of the next calendar day. So again, you would code this data element 0 no. If the DRR was not completed upon admission, then N2001 and N2003 are coded with a dash. As I've previously mentioned, CMS expects dash use to be a rare occurrence. Next, we will move on to N2005, medication intervention. The observation period for this item is from the date of admission, start of the SNF PPS stay, through discharge, and this is the discharge data element. N2005, medication intervention discharge, is completed only if A0310H equals 1. That is, the assessment is an SNF Part A PPS discharge assessment, and if that assessment is coded as yes. N2005 asks, did the facility contact and complete physician or physician designee prescribed recommended actions by midnight of the next calendar day each time potential or clinically significant medication issues were identified since the admission? So the coding response are going to be 0 no, The facility did not contact and complete physician or physician-designee prescribed recommended actions by midnight of the next calendar day, each time potential clinically significant medication issues were identified since the admission. You're going to code this data element yes if the facility did contact and complete physician or physician-designee prescribed recommended actions by midnight of the next calendar day, each time potential clinically significant medication issues were identified since the admission. You will code this data element 9, non-applicable, if there were no potential or actual clinically significant medication issues identified since admission or the resident is not taking any medications. Thoroughly instructing staff on the use of each of these codes will ensure that each code will be used correctly. Again, the item rationale for N2005 includes health-related quality of life and planning for the resident's care. Integral to the process of safe medication administration practice, as we've mentioned, is timely communication with a physician when a potential or actual clinically significant medication issue has been identified. Physician-prescribed recommended actions in response to identified potential or actual clinically significant medication issues must be completed by the clinician in a time frame that reduces the risk for medication errors and resident harm. Potential or actual clinically significant medication issues can occur throughout the resident's stay. In terms of planning for care, keep in mind that every time a potential or actual clinically significant medication is identified throughout the resident's stay, it must be communicated to a physician, and the physician-prescribed recommended actions must be completed by the clinician in a time frame that maximizes the reduction in risk for medication errors and resident harm. In terms of coding N2005, first you are going to review the resident's medical record to determine whether the two criteria were met for any potential and actual clinically significant medication issues that were identified upon admission or at any time during the resident's stay. You are going to use the same medical record sources that we have mentioned throughout this presentation. The second step is to determine if both criteria were met for all potential and actual clinically significant medication issues that were identified upon admission or at any time throughout the resident's stay. And that is two-way communication between the clinician and the physician was completed by midnight of the next calendar day, and all physician-prescribed recommended actions were completed by midnight of the next calendar day. N2005 includes all drug regimen review information that you collected and coded from when the patient was admitted throughout that patient's stay. And I can't say this enough times. It's admission through discharge. You are going to complete N2005 only if A0310H equals 1. You're going to code no if the facility did not contact the physician and complete prescribed recommended actions by midnight of the next calendar day each time a potential or actual clinically significant medication issue was identified since admission. You are going to code this data element 1, yes, if the facility contacted the physician and completed prescribed recommended actions by midnight of the next calendar day each time a potential or actual clinically significant medication issue was identified since admission. you are going to code this data element 9, non-applicable, if there were no potential or actual clinically significant medication issues identified at admission or throughout the resident's stay, or the resident was not taking any medications at admission or at any time throughout the stay. The next slide is a few coding tips. So if the physician prescribes, recommends an action that will take longer than midnight of the next calendar day to complete, then you can code this data element 1 yes, should still be entered if by midnight of the next calendar day the facility has taken the appropriate steps to comply with the prescribed recommended action. An example of a physician-recommended action that would take longer than midnight of the next calendar day to complete, the physician writes an order instructing the clinician to monitor the medication issue over the next 3 days and call if the problem persists, as I've mentioned this in previous slides. This slide depicts examples of what we mean by midnight of the next calendar day. So there's 2 examples here. The first one is a clinically significant medication issue is identified at 10 a.m. on September 12, 2017. The physician prescribed recommended action is completed on or before 11:59 p.m. on September 13, 2017. Another example is a clinically significant medication issue is identified at 11 p.m. on September 12, 2017. The physician prescribed recommended action is completed on or before 11:59 p.m. on September 13, 2017. This is a frequently asked question that we have received as we've been training all the PAC settings on this quality measure. If a provider coded item N2003 as 0 no on the admission assessment, indicating that the required follow-up action did not take place, is there a way for the facility to code N2005 as 1 yes? And the answer is no. If N2003 is coded as 0 no, then in accordance with the drug regimen review measure requirements, item N2005, which includes admission and throughout the resident's stay, must also be coded 0 no. This means that if only one of multiple potential clinically significant medication issues at admission was not followed up by midnight of the next calendar day, the facility should code N2003 admission as 0 no and N2005 admission through discharge also as 0 no. Even if only one of multiple medication issues was not addressed by midnight of the next calendar day, N2003 is always coded 0 no, indicating the required follow-up did not take place for the potential clinically significant issue identified at admission. Now we're going to get into the interactive portion of the webinar. And in the next several slides, we're going to walk through 6 clinical scenarios that will take us through coding each of the 3 data elements. So for the first scenario, the admitting nurse reviewed and compared the acute care hospital discharge medication orders and the physician's admission medication orders for Mrs. D. The nurse interviewed Mrs. D, who confirmed the medication she was taking for her current medical conditions. The nurse found no discrepancies between the acute care hospital discharge medications and the admitting physician's medication orders. After the nurse contacted the pharmacy to request the medication, the pharmacist reviewed and confirmed the medication orders as appropriate for Mrs. D. As a result of this collected and communicated information, the nurse determined that there were no identified potential or actual clinically significant medication issues. So how would you code N2001 in the admission assessment? Did a complete DRR identify potential clinically significant medication issues? And your response options are A, 0, no issues found during review, B, 1, yes, issues found during review, C, 9, not applicable, resident is not taking any medications, or D, enter a dash. And I can see that everyone has accurately responded to this question. A, 0, no issues were found during the review, and that is correct. So you code 0, no is the appropriate answer here because the admitting nurse reviewed and compared the resident's discharge medication records from the acute care hospital with the physician's admission medication orders, collaborated with the pharmacist, and interviewed the resident. The nurse determined there were no potential or actual clinically significant medication issues. In the next scenario, we are also going to practice coding N2001. Mr. H was admitted to the SNF after undergoing cardiac surgery for a mitral valve replacement. The acute care hospital discharge information indicated that Mr. H had a mechanical mitral heart valve and was to continue receiving anticoagulation medication. While completing a review and comparison of Mr. H's discharge records from the hospital with the physician's admission medication orders and admission note, the nurse noted that the admitting physician had ordered Mr. H's anticoagulation medication to be held if the international normalized ratio was below 1.0. However, the physician's admission note indicated that the desired therapeutic INR parameters for Mr. H was 2.5 to 3.5. The nurse questioned the INR level listed on the admitting physician's order based on the therapeutic range of 2.5 to 3.5 documented in the physician's note. This prompted the nurse to call the physician immediately to address the issue. How would you code N2001 on the admission assessment? Did a complete DRR identify potential clinically significant medication issues? And your response options are A, 0, no issues found during review, B, 1, yes, issues found during review, C, 9, non-applicable, resident is not taking any medications, or D, enter a dash. And B, 1, yes, issues found during review is the correct response. Coding 1, yes, is the correct answer for this scenario because the admitting nurse reviewed and compared the resident's discharge healthcare records from the acute care hospital with the physician's admission medication orders and admission note. The nurse identified a discrepancy between the physician's documented INR level of 2.5 in the admission note and the physician's order to hold anticoagulation medication for an INR level of 1.0. The nurse considered this discrepancy to be a potential clinically significant medication issue that could lead to potential clotting issues. In the next scenario, we're going to practice coding N2003. And I'm going to be asking you to code both N2001 and N2003. Mr. P was admitted to the SNF with active diagnoses of pneumonia and atrial fibrillation. The acute care facility medication record indicated that the resident was on a 7-day course of antibiotics, and the resident had 3 remaining days of his treatment plan. The nurse reviewing the discharge records from the acute care facility and the SNF admission medication orders noted that the resident had an order for an anticoagulation medication that required INR monitoring as well as the antibiotic. On the date of admission, the nurse contacted the physician caring for Mr. P and communicated a concern about a potential increase in Mr. P's INR with this combination of medications that could place the resident at greater risk for bleeding. The physician provided orders for laboratory testing so that the resident's INR levels would be monitored over the next 3 days starting that day. However, the nurse did not request the first INR laboratory test until after midnight of the next calendar day. How would you code N2001 in the admission assessment? Did a complete DRR identify potential clinically significant medication issues? And as in the previous scenarios, you have the same responses, options. And it looks like people are accurately coding, and B1, yes, issues found during the review is the correct response. How would you code N2003 on the admission assessment? Did the facility contact a physician by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issues? And your response options are A, 0, no, B, 1, yes, or C, enter a dash. And it looks like about 85% of you have selected A, 0, no, and about 14% of you have selected B, 1, yes. So we'll move on to the answer slide. And the correct response for coding N2003 is 0, no. So in summary, for this particular scenario, you're going to code N2001, yes, issues found during review, and you're going to code N2003, 0, no. And this is because a potential clinically significant medication issue was identified during the drug regimen review. The staff member did contact the physician before midnight of the next calendar day, but did not complete, to the extent possible, the physician-prescribed actions related to the INR laboratory test until after midnight of the next calendar day. The next scenario is Mrs. S. was admitted to the SNF from an acute care hospital. During the admitting nurse's review of Mrs. S. acute care hospital discharge records, it was noted that the resident had been prescribed metformin. However, admission labs indicated that Ms. S. had a serum creatinine of 2.4 consistent with renal insufficiency. The admitting nurse contacted the physician to ask whether this drug would be contradicted with Mrs. S. serum creatinine level. 3 hours after the resident's admission to the facility, the physician provided orders to discontinue the metformin and start Ms. S. on a short-acting sulfonylurea for ongoing diabetes management. These medication changes were implemented within the hour. So for this scenario, how would you code N2001 on the admission assessment? Did a complete DRR identify potential clinically significant medication issues? And your response options are similar to previous scenarios. A, 0, no, B, 1, yes, C, 9, not applicable, D, enter a dash. And it looks like 100% of our audience has selected B1, yes. And that is the correct answer. So as I've indicated, B1, yes, is the correct answer. And how would you code N2003 on the admission assessment for this scenario? Did the facility contact a physician by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issues? And your responses are A, 0, no, B, 1, yes, C, enter a dash. And again, the audience, you have accurately coded this particular clinical scenario. B1, yes, is the correct answer. We're just experiencing a little bit of a delay to the next slide. And there you have it, the correct answer, B1, yes. So in summary, for this particular scenario, you would code N2001, yes, issues found during the review, and N2003 would also be coded 1, yes. And the reason for this is that a potential clinically significant medication issue was identified during the drug regimen review, physician communication occurred, the nurse completed the physician-prescribed actions by midnight of the next calendar day, next, we're going to code N2005. At the end of her Part A PPS stay, the discharging nurse reviewed Mrs. T's medical records from the time of admission, start of SNF PPS stay, through her entire Part A PPS stay, Part A PPS discharge, and noted that a clinically significant medication issue was documented during the admission assessment. Mrs. T's medical records indicated that a nurse had attempted to contact the physician several times about the clinically significant medication issue. After midnight of the second calendar day, the physician communicated to the nurse via telephone orders for changes to Mrs. T's medications to address the potentially significant medication issue. The nurse implemented the physician's orders. Upon further review of Mrs. T's medical records, the discharging nurse determined that no additional issues had been recorded throughout the remainder of Mrs. T's stay. How would you code N2005 on the discharge assessment? Did the facility contact and complete physician-prescribed recommended actions by midnight of the next calendar day? Each time potential clinically significant medication issues were identified since the admission. And your response options are A, 0, no, B, 1, yes, C, 9, not applicable, or D, enter a dash. So how would you code N2005 on the discharge assessment for this scenario? Okay, it appears that we may be having some difficulty. Oh, here they come, the results. Okay, 81% have selected A, 0, no. And moving on to the next slide, that is the correct response. This response is 0, no, because coding of N2005 includes all clinically significant medication issues identified at admission or at any time throughout the resident's stay that were or were not communicated to the physician with prescribed recommended actions completed by midnight of the next calendar day. When reviewing Mrs. T's medical record at discharge, the nurse found that a clinically significant medication issue was identified during the admission start of the SNF PPS stay drug regimen review, but the facility did not communicate with the physician and complete prescribed actions by midnight of the next calendar day. The nurse did attempt to communicate with the physician several times by midnight of the next calendar day, but the physician did not respond until after midnight of the next calendar day. Drug regimen review, as I've mentioned, is a multidisciplinary process, and in this scenario, the physician communicated with the nurse after midnight of the second calendar day. Although no other potential or actual clinically significant medication issues were identified during the remainder of the resident's stay, the facility did not communicate with the physician and complete prescribed recommended actions by midnight of the next calendar day each time a potential or actual clinically significant medication issue was identified during the resident's SNF PPS stay. And this is our last scenario for today. At discharge, the nurse completing a review of Mrs. K's medical records found that 2 clinically significant medication issues had been identified during the resident's stay. During the admission DRR, the nurse identified a clinically significant medication issue, contacted the physician, and implemented new physician orders on the same day. Another potentially significant medication issue was identified on day 12 of Mrs. K's stay. The nurse communicated with the physician and carried out the orders within 1 hour of identifying the potential issue. How would you code N2005 on the discharge assessment? Did the facility contact and complete physician-prescribed recommended actions by midnight of the next calendar day each time potential clinically significant medication issues were identified since the admission? And your response options are A, 0, no, B, 1, yes, C, 9, not applicable, D, enter a dash. Okay, we seem to be having a delay, so I am going to advance to the answer slide. And the correct response is B1, yes. And this is the correct answer because all potential or actual clinically significant medication issues identified at any time throughout the resident's stay were communicated to the physician, and prescribed recommended actions were completed by midnight of the next calendar day after each issue was identified. While a medication issue was identified as clinically significant medication issue at admission, it was resolved by midnight of the next day. Furthermore, the drug regimen review conducted at discharge included the entire resident stay admission through discharge. Coding N2005 as 1 yes is also correct, as during the resident's stay, a second clinically significant medication issue was identified. Each time, the clinically significant medication issues were identified at admission and during the stay. They were communicated to the physician and resolved through completion of prescribed recommended actions by midnight of the next calendar day. Okay, if someone would be able to advance to slide 98, I am experiencing, I am no longer connected. If that would be possible to advance to slide 98, which is to talk about the quality measure.
I am trying to work behind the scenes to see if we can get this resolved, Harry. I'm not exactly sure what's going on.
That's okay. My colleague has it up on her laptop, and so we just advanced to slide 99. So the drug regimen review conducted with follow-up for identified issues reports the percentage of resident stays in which a DRR was conducted at the time of admission, and timely follow-up with a physician occurred each time potential and actual clinically significant medication issues were identified throughout the patient's stay. The DRR is a process quality measure that is calculated as a facility-level observed score. This is a very dense slide, so I'm going to walk you through this particular slide. To calculate the percentage of patients that successfully met the drug regimen review measure criteria, we set up a fraction. The fraction is comprised of the numerator and the denominator. The denominator for the DRR measure is the number of resident stays in the selected time window for SNF residents with a SNF PPS Part A discharge assessment, in other words, A0310H equals 1, during the reporting period. The numerator is the upper part of the fraction used to calculate the rate. For the DRR measure, the numerator includes resident stays in the denominator in which the total number of Medicare Part A SNF stays in the denominator meeting each of the following two criteria. The first criteria is the facility conducted a drug regimen review on admission which resulted in one of the three following scenarios. No potential and actual clinically significant medication issues were found during the review, N2001 equals 0, or potential and actual clinically significant medication issues were found during the review, N2001 equals 1, and then a physician or physician designee was contacted and prescribed recommended actions were completed by midnight of the next calendar day, in other words, N2003 equals 1, or the resident was not taking any medications, N2001 equals 9, not applicable. The second criteria is that appropriate follow-up occurred each time a potential or actual clinically significant medication issue was identified during the stay. In other words, N2005 equals 1, or no potential or actual clinically significant medication issues were identified since the admission or the resident was not taking any medications. N2005 equals 9. This measure has no denominator exclusions. It is a process measure, and therefore it is not risk-adjusted nor stratified. So the three data elements, N2001, N2003, and N2005, are all included, as I've just described, in the calculation of this measure. If a dash is entered for any of these three items, the resident's stay will not be included in the numerator count, but the resident's stay will be included in the denominator count. If the patient was discharged before the drug regimen review admission assessment items were completed, then N2001 and N2003 are coded with a dash. In summary, we've gone over the new Section N medications of the MDS 3.0, and we've extensively reviewed how to code N2001, N2003, and N2005. And as I've indicated, this measure assesses whether SNF providers conducted a drug regimen review upon the resident's admission and throughout the resident's stay, and whether any potential or actual clinically significant medication issues identified were addressed in a timely manner. And now I'll turn it back to you, Sharon, for questions.
Thank you, Terry. Firstly, let me apologize for the technical difficulties that we just experienced. We still have people working behind the scenes. Hopefully we can get this back up before the questions are completed. But we did get several questions that came in during the webinar, so we will start to get those questions addressed. And I'm going to just kind of read out some of them and ask someone to respond. The first question that we have is, many residents in SNFs are admitted late on a Friday night. When does DRR on admission need to be completed? Can it be completed Monday morning and still be considered timely? Terry, can you respond to that question, please?
Sure. Thanks, Sharon. And the answer to this question is no. And what we want to encourage SNFs to do is follow best practices by conducting the drug regimen review upon admission, or as close to the actual time of admission as possible. And the DRR items N2001 and N2003 would be completed upon admission or as close to the actual time of admission as possible. So waiting till Monday to complete these data elements would not be in the best interest of the patient nor an example of best practice.
Thank you, Terry. The next question. Are we required to obtain a list of residents' medications taken prior to proximal hospital stay to ensure that there were no omissions? I believe we have Casey. Casey, are you there? Can you help us with this question?
Sure. Thanks so much, Jess. Good afternoon, everyone. This is Casey Freeman, and I'm the SNF QRP coordinator, and this is a great question. The short answer to this question would be no. You are actually not required to obtain a list of medications from the proximal hospitalization, and you're not required to obtain a home medication list. It would absolutely be best practice, and we would love for you to do that, but we do understand that there would be limitations and you may not be able to access that data. So that's why it is not required. I do think it's important to point out that there are lots of sources for information to complete the drug regimen review. And, they're not, this list that I'd like to share is sort of not inclusive or all exclusive, but, there are progress notes that you can look through in the chart that were written by physicians or NPs or PAs. There's discharge summaries and discharge instructions. Just doing an interview with the patient and asking them about their medications can provide a wealth of knowledge. And then there are verbal reports that you might receive from the transferring provider. So the short answer to the question, Sharon, is really no. We don't require that you obtain a list of medications that were used at the prior hospitalization or the proximal hospitalization or the home medication list. We don't require a combination, but we do encourage you to utilize as best practice all the information that you do receive. So thank you.
Thank you, Casey, for the explanation. The next question that has come in, if a resident ends a Medicare Part A stay, remains in the SNF, and resumes Medicare Part A benefits for further covered care within 30 days of ending their prior Medicare stay, is a new DRR required with a new PPS 5-day assessment? Terry, can you respond to this question, please?
Sure. Thank you, Sharon. So the short answer is yes, and a new drug regimen review is conducted, and you would complete items N2001 and N2003 on each PPS 5-day assessment. And as I indicated throughout the presentation, that means A0310B equals 1 for all residents in a Medicare Part A stay.
Thank you. Okay. Since the drug regimen review data elements are coded upon discharge, how often would a medication review be conducted? Is documentation required that supports there is a clinically significant medication issue upon review? Terry?
Thank you, Sharon. While the items only measure drug regimen reviews conducted at admission, in other words, N2001 and N2003, I'd like to emphasize that the provider uses their clinical judgment to determine when a resident's medication regimen needs to be reviewed, including a medication review throughout the resident's stay. The timing of a formal or informal drug regimen review activities would be completed based on the resident's need, compliance with state and federal regulations, as well as any facility policies and procedures that you may have in place. An example of when you might conduct another drug regimen review might be when the resident is being transferred to another provider.
Thank you. Let's see here. I believe I have another question. Casey, I think you can answer this one. I thought, someone wrote, I thought in Appendix PP of the State Operations Manual that a drug regimen review was to be conducted by a pharmacist. Is this true? Casey?
Sharon, thanks. Yeah, that is actually a great question. So we are actually speaking about two separate processes, both sort of name the same thing. So I apologize for the confusion, but thank you for this clarifying question. Yes, this provider is correct. There is a drug regimen review that's described and outlined in the State Operations Manual, and it is absolutely conducted by a pharmacist. And it is completely separate than the drug regimen review that we spoke to and taught on today. The drug regimen review that's conducted by the pharmacist is required, it's done monthly, and it is actually a benefit or a service provided to patients in nursing homes, whether they are SNF patients or whether they are nursing home patients that are long-term patients. The purpose of this drug regimen review that's conducted by the pharmacist is very different. The pharmacist is actually reviewing all the medications the patients are on, and they're making recommendations to the treatment team. They may be recommending that this patient, they've noted this patient has been on risperidone for more than 6 months and is clinically stable, and they recommend to the physician and treatment team that they should consider reducing that medication or doing a gradual dose reduction. So that process is completely separate and different than the drug regimen review that we are conducting as a part of the SNF QRP. Our drug regimen review, as Terry spoke to today, is really to identify medication safety issues, both on admission and throughout the resident stay. It requires two-way communication with the physician or NP or physician assistant, and it applies to all Medicare Part A residents. So those are the differences. And again, thank you for the question. It is confusing because both of these processes are described as drug regimen review. Thanks, Sharon.
Thank you. Next question, can a pharmacist conduct the drug regimen review remotely via the resident's electronic health record? Terry, can you take this one?
Sure. This is a very interesting question, and certainly as skilled nursing facilities begin to implement more electronic healthcare records and more technology in our homes, I anticipate that we'll be receiving more of this type of a question. So the answer to this question is that this would be appropriate. As we know, facilities have different technology available to them, and it's also facilities deliver resident care according to their unique characteristics and standards. And so a facility is going to self-determine its policies and procedures for how they document what their documentation practices are and how they want their staff to complete the assessments in compliance with state and federal requirements. What's important is that the data in the MDS should be consistent with information in the resident's medical records. So in this case, if that's where the resident's information is, then it's perfectly acceptable to conduct the DRR via the remotely.
Thank you. Thank you, Terry. Does the drug regimen review also include the review of ointment and other wound treatments a resident is receiving? Casey?
Thanks, Sharon. This is a really common question that we've heard before, and the short answer is yes. The drug regimen review was really designed to look at every medication the patient is receiving, whether it's an ointment or a wound treatment that's using medications, or if it's vitamins or herbs, over-the-counter medications. We really need you to do a thorough review of all the medications that are being administered under your care. And I guess I also want to note that it also includes TPN and oxygen. So yes, it includes everything. Thanks, Sharon.
Good. Okay, the next question. Are the DRR data elements on all MDS assessments? Terry, can you help with this question?
Sure. The drug regimen review items N2001 and N2003 are coded when A0310B equals 1. In other words, this is the PPS 5-day assessment. And then item 2005 is coded when A0310H equals 1, the Part A PPS discharge.
I think I have a couple other questions here. I think we will have time to go through and get some responses with. How about this one, Terry? Would use of a medication without indication for use be classified as a potential or actual significant clinical significant medication issue. An example would be the use of an antipsychotic medication without a diagnosis. Terry, can you respond?
Sure. So again, this is another very interesting question, and this particular question might be an example, as would use of any medication without evidence of an adequate indication for use. And again, the clinician is going to use their clinical judgment in determining if this is a clinically significant medication issue. As I noted in the presentation, use of a medication without evidence of adequate indication for use is one example that may be a clinically significant medication issue. And I'd also like to stress or ask you to remember that any of the examples that we presented today of a clinically significant medication issue must reach a level of clinical significance that warrants notification of the physician designee for orders or recommendations by midnight of the next calendar day at the latest. And I'd also like to stress that any circumstance that the clinician feels does not require this immediate attention is not considered a potential or actual clinically significant medication issue for the purpose of coding the drug regimen review items.
Thank you. I think we have time for maybe just one more question. Who can complete the DRR? Are state licensed registered nurses authorized to complete, or must it be an advanced practice nurse, physician assistant, physician, or pharmacist? Casey, can you take this question, please?
Sure. Thanks, Sharon. This is a great question, and I think the biggest message that I can provide is that CMS does not mandate who should do the drug regimen review. And I know that that's vague, and it might not be the answer that people are seeking, but it is the best answer because that decision actually needs to be made at each individual facility, and we really encourage providers, we need you to refer to your state and federal guidelines to decide who can complete the drug regimen review in meeting your state and federal guidelines. So I wish I had a clear answer, but the answer really is CMS does not mandate who should do the drug regimen review. Thanks, Sharon.
Thank you. I'm sorry, we are out of time for today's webinar. We have responded to several of the questions that were submitted today, and we do apologize if you submitted a question and was not answered during the webinar. But answers to the general questions will be posted at the CMS Skilled Nursing Facility Quality Reporting Program webpage, along with the Q&A document. And some questions may be responded directly to specific providers by the help desk. Before I wrap up today's event, I just want to say thank you to Terry and Casey for sharing their valuable knowledge, in particular Terry for the presentation and Casey providing support for the questions. But this certainly includes the SNF Quality Reporting Program, Drug Regimen Review conducted with follow-up for Identify Issues webinar. We also just want to let you know that the full version of the slides, including the answers to the polling questions, as well as a recorded version of this webinar, will be posted, and we will send an email notifying you when and where those items have been posted. Thank you all very much for attending. Have a good day.
This concludes today's webinar. Thank you for attending.